السلام عليكم ورحمة الله وبركاته. موضوعنا لهذه الليلة Bronchodilators and Respiratory Therapy. And this is our outline. We will start with the principles of pharmacology and then Adrenergic Bronchodilator, Anticholinergic Bronchodilators, mucus controlling agents, inhaled corticosteroids, non-steroidal anti-asthma drugs, aerosolized anti-infective agents, inhaled pulmonary vasodilators and their references. The course of drug action from dose to effect comprises three actions: drug administration, pharmacokinetics, pharmacodynamic phases. Drug administration describes the method by which a drug dose is made available to the respiratory tract through inhalation route. It can be aerosol, liquid, solution, suspension, or dry powder form. Most commonly devices used are metered dose inhaler, soft mist inhaler or Respimat, small volume nebulizer, dry powder inhaler. Disadvantages: doses are usually smaller than doses for systemic administration. Onset of drug action is rapid. Delivery targeted to the organ required treatment, and systemic side effects are often fewer and less severe. Disadvantages: number of variables affecting delivered dose and lack of adequate knowledge and use among patients and caregiver. Pharmacokinetic phase describes the time, course, and disposition of a drug in the body based on its absorption, distribution, metabolism, and elimination. Inhaled aerosol are intended for local effects in the airway. On the other hand, undesired systemic effects result from absorption and distribution throughout the body. The ideal aerosol would distribute only to the airway, with none reaching the stomach. The ratio of lung availability to total systemic availability quantifies the efficiency of aerosol delivery to the lung through this equation: lung availability over lung plus gastrointestinal availability. Pharmacodynamic phase describes the mechanism of drug action by which a drug molecule causes its effects in the body. Its effects are caused by the combination of a drug with a matching receptor. For example, signaling mechanism and example mediated by G protein guanine nucleotide linked receptor, and its example are beta adrenergic agonists, antimuscarinic agents. And on the other hand, attachment to intracellular receptors by lipid-soluble drugs, and its example is corticosteroids. Pharmacological control of airway is mediated by receptors found on airway smooth muscle, secretory cells, bronchial epithelium, and pulmonary and bronchial blood vessels. There are sympathetic and parasympathetic receptors in the lung. The terminology for drugs acting on these receptors is based on the usual neurotransmitter that acts on the receptor. For example, this table shows the receptor and its neurotransmitter. Sympathetic or adrenergic, its neurotransmitter are norepinephrine and epinephrine. And parasympathetic cholinergic, its neurotransmitter is acetylcholine. There are two terms, agonist and antagonists. Agonists as stimulating agents and antagonists as blocking agents, a classification of agents that act on these receptors. The terms muscarinic and antimuscarinic distinguish cholinergic agents whose action is limited to parasympathetic sites. For example, newstigamine is a cholinergic drug that increases receptor stimulation at both sites, myoneural junction and parasympathetic site. By contrast, atropine is an antimuscarinic agent that blocks the action of acetylcholine only at the parasympathetic site. And this table shows the receptors and its neurotransmitter and their actions. This table is very important. It shows the locations in the human body and the receptors located in these areas and their effects. It summarizes the whole pharmacology principle in the human body. Location or areas and its receptors and their effects. I'll capture this later. Adrenergic bronchodilators. Indication for use is the presence of reversible airflow obstruction. Indication for short-acting agents. Relief of acute reversible airflow obstruction in asthma or other obstructive airway diseases. They are termed rescue agents according to the National Asthma Education and Prevention Program. Indication for long-acting agents, maintenance bronchodilation and control of bronchospasm and nocturnal symptoms in asthma or other obstructive diseases, such as COPD. They are considered controllers due to its slower time peak effect. Indication for racemic epinephrine, its strong vasoconstricting effect to reduce airway swelling after extubation or during epiglottitis, CROP, or to control airway bleeding during endoscopy. This table summarizes ultra-short-acting, short-acting, and long-acting adrenergic bronchodilator agents and their brand names, receptor preference, adult dosage, and time course, onset, peak, and duration. Adverse effects of adrenergic bronchodilators include dizziness, hypokalemia, loss of bronchoprotection, nausea, tolerance, tachyphylaxis, and worsening ventilation perfusion or VQ ratio. Anticholinergic bronchodilators. A cholinergic blocking agent is effective only if bronchoconstriction exists secondary to cholinergic activity. Indication for use, presence of reversible airflow. Indication for anticholinergic bronchodilators, bronchodilatory maintenance treatment in COPD, including chronic bronchitis and emphysema. Indication for combined anticholinergic and beta-agonist bronchodilators, such as ipratropium bromide and albuterol, Compivent Respimat, as indicated for use in patients with COPD receiving regular treatment who require additional bronchodilation for relief of airflow obstruction. Anticholinergic bronchodilators mode of action. They act as competitive antagonists for acetylcholine at muscarinic receptors on airway smooth muscle. They have affinity for M1, 2, 3 receptors. However, the main difference is how slowly they dissociate from the receptor. Mucus controlling agents. 2 agents approved in the United States for oral inhalation with an effect on mucus are N-acetylcysteine and Tornaz alpha. Both are mucolytic, but they differ in mode of action. And this table shows agents available for aerosol administration. N-acetylcysteine first is given by either nebulization or direct tracheal instillation. It's indicated to reduce accumulation of airway secretions. Its mode of action is to reduce viscosity of mucus by substituting its own sulfihydryl group for the disulfide group in mucus, breaking a portion of the bond forming the gel structure. During physical contact with mucus, it begins to reduce viscosity and mucolytic activity increases with a higher pH of 7 to 9. Side effects include irritating or feeling of irritation in the airway and can produce bronchospasm. Dornase alpha is a genetically engineered clone of the natural human pancreatic DNase enzyme, which can digest extracellular DNA material. It is a peptide mucolytic and can reduce extracellular DNA, and it is designed as an orphan drug. Dornase alpha is indicated in the management of cystic fibrosis to reduce the frequency of respiratory infections, requiring parenteral antibiotics, and to improve pulmonary function of these patients. Mode of action: it's a proteolytic enzyme that can break down DNA material from neutrophils found in purulent secretions. It is more effective than acetylcysteine in reducing the viscosity of infected sputum in cystic fibrosis. Its side effects includes pharyngitis, voice alteration, laryngitis, rash, chest pain, and conjunctivitis. It's contraindicated for hypersensitivity to Dornase. For those who have hypersensitivity to Dornase, Chinese hamster ovary cell products, or other components of the drug preparation. Inhaled corticosteroids. They are endogenous hormones produced in adrenal cortex that regulate basic metabolic functions in the body and exert an anti-inflammatory effect. All corticosteroids are glucocorticosteroids. They are used to treat asthma and COPD. Indications and purposes: 2 general formulations of aerosolized glucocorticosteroids are orally inhaled and intranasal aerosol preparations. Glucocorticosteroids, mode of action: they are lipid-soluble drugs that act on intracellular receptor. Here is an important point. For patients to understand that inhalation of an aerosolized steroid does not provide immediate relief as with an adrenergic bronchodilator. However, daily compliance with inhaled medication is essential to controlling the inflammation of asthma. بالعربي، من المهم أن يعي المرضى بأن هناك فرق في المفعول ما بين الايروسولايز ستيرويد and الادرينرجيك برونكودايليتر. على الرغم من ذلك، الالتزام بالجرعة اليومية يحد من الأعراض المصاحبة. Non-steroidal anti-asthma drugs. They are indicated for clinical use as prophylactic management of persistent asthma. Adverse effects include inappropriate use. These agents are not bronchodilators and offer no benefit for acute airway obstruction in asthma. This table shows a summary of comparative features of 3 available anti-leukotriene agents in terms of these features on the left. Lastly, inhaled pulmonary vasodilators, including nitric oxide. It is indicated in treatment of neonates of more than 34 weeks of gestational age with hypoxic respiratory failure. Patients should have evidence of pulmonary hypertension, in which it would improve oxygenation and decrease the need for extracorporeal membrane oxygenation. Its mode of action basically produces pulmonary vasodilation, reduce pulmonary artery pressure, and improve VQ mismatch. It is contraindicated in neonates with dependent right to left shunt. Precautions include methemoglobinemia and nitric dioxide formation. The most common adverse effect events are hypotension and withdrawal. Iloprost is indicated for treatment of pulmonary hypertension. It is administered with INEP nebulizer. Its mode of action: dilate pulmonary arterial vascular bed and affects platelet aggregation. It is unknown whether platelet aggregation plays a role in the treatment of pulmonary hypertension. Adverse effects include syncope and pulmonary edema, which may occur secondary to vasodilatory properties of iloprost. During the 12-week clinical trial, headache and increased cough were the most noted adverse reactions. Treprostinil is indicated for the treatment of pulmonary arterial hypertension to increase walking distance in patients with New York Heart Association Class 3 symptoms. Mode of action: vasodilation of pulmonary and systemic arterial vascular beds and inhibits platelet aggregation. Adverse effects: it is not being studied in patients with underlying lung disease. It may cause bronchospasm. This agent shouldn't be mixed with any other agent. And the last, this is the reference. Thanks for listening and watching. Hope you enjoyed it. Wassalamu alaikum wa rahmatullahi wa barakatuh.